questions then? Yes. We're flexible. We're flexible. All right. So, did she really? Thank you. Thank you. So I'd like to introduce right now two very distinguished neurologists who have served on our scientific advisory board and hopefully our medical advisory board for a very long time. And I am so pleased to be able to have them here. We're going to do this in a somewhat different format. We're sort of going to do questions and answers. I have a bunch of questions that were submitted ahead of time. We may have enough time to have you all ask questions as well. I'd like to introduce Dr. Rustam Al-Shahi Salman, who is Professor of Clinical Neurology, Head of the Cerebrovascular Research Group, and Clinical Director of the Edinburgh Clinical Trials Unit at the University of Edinburgh. And Dr. Kelly Flemming, who is a neurologist, and she is the co-director of our Mayo Center of Excellence. Many of you know her from seeing her personally or from the many webinars she's done with us. And she is also now the vice chair of our new medical advisory board. We are going to try really hard to talk into the microphone because we're recording this for posterity. It'll be up on YouTube. When it's time for you to ask a question, please wait for us to get the microphone to you so that the audience can hear your question. The other part of this is if we get to your question and it's got personal information, if you could hold that till after the main question session so that we can cut that from the video when it's time for us to try to put it on YouTube, because we don't want to have any issues with your confidentiality. All right, let's get started. All right, my first question is on a different sheet of paper. Is about symptoms. So why is the term incidental used when a cavernous malformation is found on an MRI, especially when the patient feels that they're having symptoms and that an MRI was ordered because of some sort of symptoms? So why would you call a cavernous malformation found then incidental? And there's a gentleman here who actually wrote a paper called Incidentalomas, so he may have something to say about that.
Well, thank you very much, Connie, and it's nice to see everybody. It's a tough one to explain, but it's really quite straightforward conceptually, in that many of us harbour things in our bodies that we don't even know about, and we carry around potentially for the whole of our lives and remain undetected, and we may not find them unless we have a scan that reveals them. So we did a study about, as Connie says, incidental omas, and we put together about 19,500 people who had no neurological known disease, who underwent brain MRI, and that might be as part of commercial health screening. If you want to be a Luftwaffe pilot in Germany, you have to have a normal brain MRI scan and a normal EEG recording in order to fly. So these people are all sorts of different ages, sexes, parts of the world, and they underwent brain MRI. And we found all sorts of incidental abnormalities in the brain. And for CCM, 1 in 625 people had a CCM, and they'd never had a neurological disease or condition diagnosed before. Some of those people may have had neurological symptoms, and headache, for example, is the commonest neurological symptom, but very often there is no structural problem in the brain to cause the headache, and the fact that you find a structural problem in the brain like a CCM doesn't necessarily mean somebody's headache is due to it. So we recognize migraine headaches very clearly as neurologists, and I see lots of people with migraine and no CCM in their head. And then I see people with CCM, some of whom have headaches and migraines exactly like the patients I see with a normal brain scan. So this incidental concept relies on us understanding that we are not all normal on the inside, and also that we may often have symptoms that can't be explained by a structural problem. It may be explained by some other mechanism that our scans can't see. So I really understand why people make the link between their symptoms and something on a scan because it seems logical to blame it. But actually, when you see a broad spectrum of people coming into your clinic, it gives you a slightly different perspective. So of course it's easy for me to say migraine is almost always incidental to CCM, and that's not to make light of anybody's symptoms, because we can help with those symptoms as neurologists. It's just to say it's not necessarily the CCM. But Kelly may have another perspective.
No, I completely agree with that. Incidental meaning asymptomatic, that we think it's separate from the symptoms. And so when I see a patient, the first thing I do, I have sort of this approach where first I want to make sure that the lesion we see on the brain is really a cavernous malformation and not something else. So before we go down the pathway about talking about cavernous malformations, are we sure that's what it is? And sometimes that requires repeat imaging. Secondly, I try to decide, is it the familial form or not, and have they had the right imaging? Because if you didn't have SWI or GRE imaging, maybe the symptoms are due to another lesion that we just don't know about yet. And then third, I look at what are the symptoms. Do they match anatomically with the place in the brain that the cavernous malformation is? What does the radiographic features look like? Does it look like it's recently bled? Is there some edema? Is there some other feature that makes me think that's the symptom? But as Rustam said, is oftentimes, I would say 90% of the time, we know right away, is it symptomatic or not? And I'd say there's a handful of patients that it looks like a little bleeding and it's in a sort of nebulous place in the brain where and sometimes cognitive issues are a little bit hard to sort out. But I would say that's the rare person. And if you ever have concerns, I always suggest getting a second opinion. It's always worth, with cavernous malformations, getting a couple opinions, since it's a rare disease and physicians that you see may not have encountered as many as maybe a high volume center.
My follow-up to that for you is, you've done some research looking at lesions that have never hemorrhaged, so in some cases probably incidental lesions, and what the natural history of those lesions tends to be. Can you share that?
Sure. Sure. So we've looked at what happens if you don't, no surgery, no medications, what happens in time if you have an incidental asymptomatic cavernous malformation. And we're continuing to look at that because our initial data was maybe five years of follow-up, and now we have closer to 10 years of follow-up and even longer. But the risk is very low of a future hemorrhage if it's an incidental finding. Now, that being said, the familial form is a little different because there's multiple lesions, and that may be different. But for the sporadic form, the risk is very low. And when I say very low, I mean like less than 0.5% per year, and probably closer to 0.1% per year.
All right, next question is still along those lines. Are there current or upcoming tools that would allow us to better understand what symptoms come from what lesions, since there often is disagreement between patients and their physicians?
I would say there's not often a lot of disparity, but the tools that we can use if we needed to would be things like functional MRI sometimes can be useful, where while you're in the scanner, they have you speak or they have you do a task and it lights up on the brain as what's going on. Occasionally I've done SPECT or PET scans trying to localize things, but I mean, these be the very rare, and oftentimes those scans aren't covered by insurance depending on the indication. So I would say it's very rare that we have a dilemma about is it causing the symptoms or not. And then the question becomes, even if you think it is it in a location you can get to with surgery or not, and would you take a 50-50 chance of wanting it removed?
So a neurologist's job is to listen to the person in front of them and to get the whole story and listen deeply to their symptoms, and then to say what might be responsible for those. And the way we do it is to work backwards from the problems somebody is experiencing and say, can I localize that, that's the word we use, to a part of the brain. So the way we teach medical students in the UK anyway with neurology is the first question you ask yourself after listening to your patient is, where is the lesion? And then the second question is, what is it? In other words, we don't have a scan first, think later approach. We're saying, where are these symptoms coming from and what might it be due to. So when we talk to people with CCM, if, for example, like many of the CCM we've just seen on the scans here, somebody with a pontine CCM has an eye movement problem and they're off balance, you know, it's easy to localize those symptoms to that part of the brain. So we can say those symptoms are due to the CCM. The other thing to recognize is what we heard yesterday in the international meeting, where all these health-related quality of life and other scales have captured the symptoms patients with CCM have. And some of the most common ones are fatigue, anxiety, sleep disturbance, and many of those things cannot be localized to one part of the brain. That's a very general symptom. So often somebody with a pontine CCM who is unsteady and has double vision will also have fatigue, anxiety, sleep disturbance. So I think it's important to recognize that not all symptoms can be localized to the CCM, but we use the symptoms that can be to say, has that CCM caused symptoms or not? And then those people also have lots of other really important symptoms that can't necessarily be localized. The difficult category is people who have symptoms that you can't localize to anywhere in the brain. Let's say just fatigue, just anxiety, and there's a CCM there. And that's what we find really hard to pin to a particular location. And that's when we might say the CCM's incidental.
Then actually, the next question is very similar to that, to ask you to expand on that. Is there a way to tell the difference between, in this case, the person asked medical PTSD versus a lesion-related neurosymptom? Or I will also ask endogenous anxiety, some sort of anxiety that is coming from in the brain versus anxiety that's coming because there's an emotional reaction to having something in your brain, or depression. How is it that you can differentiate the psychiatric, environmentally, externally caused versus the psychiatric that's caused by lesions?
I don't think you can. I don't think you can. And it's as you mentioned, there are places in the brain that definitely have to do with anxiety, that psychiatrists have done studies looking at, the happy chemicals. Serotonin is produced in the brainstem, dopamine is produced in the brainstem, and it talks to the amygdala, which is kind of the fear part of the brain. And so it's possible that some of these things could exacerbate anxiety, but it's impossible to prove. And I think it again comes down to, would you take a lesion out, for instance? How does it change management? And would you take a lesion out just because of that symptom? And probably the risk of taking it out is greater than the benefit. So ultimately, we treat the anxiety the same way you would treat anxiety with that's organic or from a lesion. Sorry.
So, but what about like pharmacological treatments being tested in the future for, like, could anxiety be measured as being a clinical endpoint for a treatment, reduction in anxiety? Or
so yesterday I showed some data where patients that didn't have surgery, we looked at scores of anxiety at baseline after somebody had had a hemorrhage, and then at 1 year and 2 year, and we see that without surgery that the anxiety does fall over 2 years. And so it doesn't fall to zero, so there's a small margin where there's some patients that would benefit from looking at medication, but it does naturally also improve with time. I don't know if you have thoughts on that too, or?
It's really understandable for people who've had seizures or a bleed from a CCM for them to feel anxious. And if they don't have surgery, to be anxious about a rebleed. If they do have surgery, to be anxious about whether the CCM will recur and whether everything's going to be okay. So some very understandable explanations in reaction to what people have experienced. But I don't believe that one can differentiate psychological symptoms that are due to the CCM from those due to a reaction to the CCM. But I'd expect, Connie, in treatment trials where we must measure those domains because they're very important to everybody in their everyday life, that we might at least see a beneficial treatment, a cure, as you like to say, for CCM, would have an effect on these. Because if there's an effect on bleeds and seizures, then the psychological symptoms in reaction to those should also be helped. But whether there's a medication that's going to specifically help anxiety and depression in people with CCM, I don't think that exists.
All right, I'm going to move into different areas. There is a question about pain and pain management. Are there any pain medications that would be safe for people with CCM other than paracetamol, which is acetaminophen here?
So there's several kinds of pain that occur with cavernous malformation. So I'm not exactly sure what they're talking about, but there's a specific kind of pain called neuropathic pain that's common in spinal cord cavernous malformations, common if you have a medullary, which is a part of the lower brainstem, or of the thalamus. That's a very burning, nagging type pain. It's very hard to treat. We usually start with medications, oral medications, things like amitriptyline, nortriptyline. They're called tricyclic antidepressants. We try gabapentin, which is another anti-seizure medication that tends to help pain. In some patients, if it's a spinal cord lesion, sometimes they'll do spinal cord stimulation. The rehab folks will do desensitization therapy. And there may be, I was talking to one of my pain colleagues in our pain clinic, the medical marijuana may be an option for that kind of neuropathic pain as well. I can talk more about headache too, which is different, but do you have neuropathic pain thoughts? Or?
No specific additional recommendations, but I think the pain that's measured that also registers quite highly on many of the scales that have been used in cohorts of people with CCM, which we heard about yesterday. A lot of that, the majority of that pain will be from headaches patients are experiencing, but there are some extremely difficult to treat types of pain, like spinal cord related pain. But there's a whole range of medications we can use for migraine now to address pain there. I mean, it's really a very progressive area, all sorts of monoclonal antibodies now for acute pain relief. There needs to be more progress with migraine prevention therapies, but there are at least 2 or 3 drugs that are well proven for that, and maybe acupuncture and other complementary therapies too can help. So I think there's a lot that can be done, and as you've heard already with the centres of excellence, that multidisciplinary involvement and involving neurologists and pain specialists is the key.
Thank you. Thank you. Some mechanism questions, or at least one. How does lesion activity affect the surrounding brain tissue and function? Is it only the blood byproducts, so the hemosiderin, irritating the tissue, or is there more? And the person follows on with, I've heard in webinars and from peers that seizure activity, for example, changes things in parts of the brain surrounding the activity. So tell me more.
So the way that cavernous malformations cause symptoms are several. So they can bleed, and so then they push the structures around them. They can push the structure called the ventricles. So the ventricles, if you think about like a funnel, there's a funnel in the brain that makes spinal fluid, and it funnels down into the what we call the subarachnoid space. So if you push on that structure, you can get hydrocephalus, which is too much pressure on the brain. So symptoms can be from that. Symptoms can be from seizures, which we think are probably little either from a bleed or a little micro leakage around there. But with seizures, uncontrolled seizures that are difficult to control with medications can ultimately cause permanent brain issues that will then make the seizures very difficult to treat. So seizures beget seizures. So if you don't treat them, they can actually cause kind of damage to what's called the hippocampal region of the brain, and people's seizures can be persistent and make it harder to treat surgically if that's recommended.
Yeah, and just to add to that, there's this phenomenon of kindling, isn't there, Kelly, where, seizures, if they're allowed to continue or not controlled, may, like kindling to start a fire may further aggravate the seizures. So that's also led to theories, and it has probably affected clinical practice too when it comes to epilepsy surgery. So, traditionally, patients with epilepsy will have to fail several anti-epileptic drugs, have an extensive workup, and really demonstrate that medical therapies failed before having epilepsy surgery to remove a lesion, whether it's CCM or something else, as the cause of epilepsy. Whereas some observational studies where we see what happens to people with epilepsy who have early surgery versus those who are left to a traditionally later time point suggest that early epilepsy surgery, which is different from just taking the CCM out, it's about mapping the surrounding brain, taking extra brain very carefully, removing, as the questioner says, the hemosiderin ring 2, that can be more successful. So that's a promising approach. Ideally, you test it in a randomized control trial to know for sure that that's beneficial, because epilepsy surgery is a major undertaking and does have side effects. So yeah, that theory that they're referring to affects the way we're treating patients nowadays.
Thank you. Kelly, do you feel comfortable answering the hormone question now? Okay, all right. I just
More
didn't want
comfortable than me, anyway.
Well,
Connie.
no, I know that there's stuff that's getting that's not quite published yet. So the question is, I would like to know about hormones and cavernous malformations, the risk with menses, pregnancy, fertility treatments, and hormone replacement therapy.
Oh boy. So I can start with the easy ones. There's no current data on fertility drugs and cavernous malformations and what that happens with that. There's no data on intrauterine progesterone-only IUDs, so not data on that. There's patients that will tell me that with their menstrual cycle that their cavernous malformation symptoms seem more dramatic at that time. There's no data that confirms that, but I believe the patients that are telling me because they know their bodies very well. In terms of pregnancy and hormones, so what we know from several large studies is that the risk of pregnancy does not, or sorry, the risk of bleeding during pregnancy does not seem to be higher than that during the non-pregnant state. Although most patients often are diagnosed in their 40s and higher, so they've often had their children before knowing that they had the cavernous malformation. But that's data from several large series suggesting, again, that the pregnancy and non-pregnant state, the rates of hemorrhage are similar. And of all the case reports and all the medical literature, no one has had a hemorrhage of the cavernous malformation during delivery. So we can be comfortable with that. Patients can undergo a normal vaginal delivery should they have no other reason to undergo a C-section. So with pregnant patients, I often go over, is it the familial form or not, and do they need counseling about the risk for the fetus? Is the patient on seizure medications? Do they need to be on an alternative seizure medication because of the risk to the fetus? And then what to do if they have symptoms during pregnancy, because an MRI scan without gadolinium could be safe. And then to the hormone question, our oral contraceptives with estrogen are Prempro or vaginal estrogens and those sort of things safe. And yesterday I gave a presentation on this, and it's not published data, and it's epidemiologic data, so there are some limitations to it, but what we did see was that, especially with the doses of estrogen, that the oral contraceptive, that there is a slight increased risk of hemorrhage in females that are taking oral contraceptives, whereas the menopausal therapies are lower dose estrogen and don't seem to have the same risk. Now, that being said, there are a lot of limitations to our paper and our study, and we're trying to look at it further in terms of the doses of estrogen, the types of progestin that were combined in those, in the patient characteristics. What were the characteristics of the patients that were also on the contraceptives? Because there might be a third factor that makes certain people more at risk than others. So I think it's a good thing to individually talk to your physician about your particular situation, because it may be different for different patients.
Did you want to talk to that or not? You don't have to.
The only additional point I'd make, and not as a man, just regardless about the perspective, is that these things need to be seen in more than one dimension. So obviously when considering the risks of the oral contraceptive pill for women, there are also benefits of them taking that pill for whatever reason, whether it's their menstrual cycle, whether it's not wanting to fall pregnant. And those benefits, although they can't be numerically compared to the increase in risk of CCM bleeding, they're really important to the women in question. And so it's very much a value judgment that needs to be seen in the round, and our job is to empower the woman to make that decision with the information on both sides, and help her make a balanced decision in more than one dimension.
Thank you. All right, I'm going to ask one more question, and then I'm going to go around and see if anyone out there has a question. But let me ask the last one first, and think about your questions in the meantime. What kind of client information or patient information is most helpful to hear or read via a patient portal or email systems and in appointments? How much is too much or too little? Should patients be, this is a multi-part question, should patients be tracking symptoms in a more structured way, like with a diary or an app?
Shall I give you the British perspective first?
Yes, that's fine.
I think healthcare consultation and doctor-patient interaction is quite different in the UK. It's not uncommon for me to see a patient and then for them to reach into their pocket and not pull out their passport, but to pull out a list of questions, and that's fine. I think that really helps the consultation. It allows somebody to feel that they fully explained themselves. And when I go and see a doctor, I often need to make a mental list as well, because it's a time pressure consultation. So I think that's absolutely fine. If somebody wants to send the information ahead, that's an effective way of receiving the information, but promising a detailed reply is another matter. And I think these things often are best borne out in discussion rather than lengthy email dialogues, to be honest with you. And what's actually useful and most informative, well, the thing that's most going to influence whether I'm recommending treatment or no treatment or altering drug therapy is whether somebody has had more symptoms to suggest further seizures, or symptoms to suggest that they need another scan because they have symptoms referable to the anatomical location of the CCM, and it might be enlarging or it might have bled. That's what's going to influence treatment. But having an app that's giving me, lots of information about fluctuation in pre-existing symptoms day to day isn't going to change whether we're recommending surgery or not.
Yeah, so I think the patient portal, which is what we have, if you're in an Epic system, it's kind of it's a double-edged sword, because it's great because we can communicate very quickly, but I don't know if people realize that we're given, at least at our institution, given no time to do those messages, so it's all on our own time. So if you get too many messages, I apologize, I can't get them back to you immediately because of the volumes. So I often collaborate with patients to tell them, here's when to contact me, or like if we start a new seizure medication, I want to hear from you in 6 weeks. Can you update me through the portal? Or if you're having an increased number of seizures, it's better to just call me, because the message system is going to be too full for me to kind of weed through it. So we try to talk through each individual person's situation to decide when is it best to call, when is it best to send a portal message, when is it best to go to the emergency room, because sometimes it's better to go to the emergency room than to wait for me for a day or two to send you a message back on the portal.
Okay. Who has a question? Oh my gosh. All right. I'll start and I'll kind of work my way around here.
Thank you so much. My name's Seema, and I have CCM. So 2 questions was regarding when you were talking about different kinds of pain medication. If you don't mind telling us what those are, what are the different kinds of pain medication that you would recommend, and if there are any that you don't recommend, and same thing for the seizure medications.
Let me clarify. Do you mean pain medicines for migraine or pain medicines for neuropathic pain? Okay.
Yeah.
Again, for neuropathic pain, things like what are called tricyclic and antidepressants, so nortriptyline, amitriptyline tend to work well for neuropathic pain, and then gabapentin, which I probably prefer better than the tricyclics just because it has less side effects, less interactions with other medications. So those are common ones. If it's a small area of neuropathic pain, there's topical formulations of those same medications. So for neuropathic pain, that's what I tend to use. Other things
I think you've asked us an enormous question, and to both of those, we could be here for hours explaining the therapeutic approach to pain and epilepsy. It's not to belittle the question at all. It's just that we couldn't give a comprehensive answer. Every year there's a new anti-epileptic drug coming on the market. These are huge therapeutic growth areas. So it could explain the principles of management, and there's a ladder for both of them. And you generally will start with simple evidence-based approaches. You might even start with simple or combination analgy.
Maybe a better question is then how should patients navigate that as far as figuring out which medication to go after? Because if it could take you an hour, it would take a patient 1,000 hours to figure that out. So how do we know what to ask for?
I think the thing to do is tell the neurologist your symptoms, and the neurologist will help guide you through that, because the quality of the pain, whether it is neuropathic or not, requires careful attention. How often it's happening, how severe it is, whether it's provoked by particular things. All of these will influence choices of drugs and other non-pharmacological approaches. So that drugs aren't the answer to this. It can be a multidisciplinary approach to managing pain, as well as actually seizures. It's not just about anti-epileptic drugs. There's vagal nerve stimulation, all sorts of things that are used. So I'm not hedging my bets, but I think the key is to have a good relationship with the clinician looking after you, who can help guide you through that process. I think it would be really hard for patients to know what they should be asking for. You deserve good clinical assessment and advice, and not to have to make those decisions yourself.
I'll quickly add that there's very few medications that we would limit in cavernous malformations, because that's one of my areas of interest, is looking at all sorts of different medications in terms of, are they increasing the hemorrhage risk? And there's very few that do, except the estrogen kind of came through. So
along those same lines, what do you think about non-steroidal anti-inflammatories?
good one. So that was a very good question, because I have patients that are told absolutely never, that's a bad thing. And so we've looked at NSAIDs, again, in usual doses at intervals that are not determined, but we haven't seen an increased risk of bleeding in the patients taking them. That being said, I would not take them around the time of an acute hemorrhage, but thereafter I usually tell patients, for various other reasons than the cavernous malformation, is if you limit yourself to 1 to 3 times a month, that's probably enough, because it can affect the kidneys, it can affect your blood pressure, it can affect your stomach, it affects a lot of other things, and so we don't like people using it every single day for various reasons.
Seema, I'm going to move on. Okay, sorry. Yes, I can ask you a question later. Okay, we're really short on time. Margaret.
I'm not sure how. Pfizer? Okay. I had a question about the Pfizer treatment. I have a familiar CCM, and we wanted to know about the Pfizer treatment that's going on, as far as a cure or a treatment of the CCM to as a cure for it. I'm not sure if.
So there are several.
Yeah, I think it's biotics. Yeah.
I'm not aware of specifically what you're talking about, the 2 trials that
Yeah, we'll talk about trials this afternoon, and it's Recursion and Neurelis that are coming to talk about their trials.
Hi, I have a brainstem cavernoma, and I had 3 different opinions on the rebleed rates, and all of them said around 3%, but everything I read in the literature is higher, 30 to 50%. Is that like a CDC guideline or like a medical guideline that's, or?
Yeah, so it's really difficult contending with opinion and evidence, and you rely on the doctors looking after you to quote the best available evidence, and they won't always have those numbers at their fingertips, but they should be encouraged to do so. And you've seen on the slides earlier that Dr. Hassan presented very wide ranges, as he quoted, in the percentages of patients who may present with particular symptoms, but we can give more precise estimates now about risks of future bleeding. So to my knowledge, the best available evidence, not just because I pulled it together, but Kelly was involved and so were others, the best available evidence about bleeding risks is from a whole group of studies that we put together from Mayo Clinic, Scotland, elsewhere in the world, in the Lancet Neurology a few years ago, and it's open access online. And it looked at the average risks for patients and also looked at risk factors. And you saw several risk factors on a slide earlier, and we investigated many of them. But the only 2 that consistently come out in most studies is brainstem location to increase the risk, and previous hemorrhage increases the risk of having another one in comparison to somebody who's never had a bleed. Those are your 2 rock-solid predictors. Things like size, sex, which wasn't a risk factor, multiple CCM wasn't a risk factor in the analysis we did with over 1,000 patients, and that's the way to really distill these. Small studies give you spurious answers. You need precision and large numbers. So what that showed was that brainstem CCM have the highest risk of rebleeding, but that annual risk of rebleeding goes down as time passes after the original bleed. So the further out you are, the lower the risk becomes. But we only quantified those risks over 5 years because doing really long-term medical follow-up studies takes a lot of money, and many grant funding agencies, as we were discussing yesterday, limit themselves to 5-year time windows. So knowing what somebody's lifetime risk of bleeding is genuinely unknown. We can do back of the envelope calculations and take a percentage risk and extrapolate it and say, let's suppose you live a normal life expectancy and you have no other health problems, this might be your risk, but that's an assumption. So I find it I don't know about you, but I can't make decisions further than 5 years ahead in my life. And I think we can only really focus on risks of one thing versus another over the following 5 years. So I think that's a useful time horizon. Be happy to look up the paper or share it via Connie so that you can look at your specific risk. And I can't remember every percentage in every category. I look it up myself. I think we have to do that. But really, doctors should use the best available information. And I don't blow my own trumpet, but that is the best information.
All right, Candy has a question. Hi, I have a very brilliant doctor. I have a 2-part question. I was told by a neurologist that memory and the place where you may have a cavernous malformation seems to be linked with the other people that have a cavernous malformation in the same spots. I also have another question. What would you suggest if a patient could be having new type of seizure and previously controlled headaches are now having headaches?
An office consultation.
Well, we need to chat. No, I think this cognitive issue with this, especially the familial form. I mean, there's strategic lesions. If you think of certain places in the brain, there's a place called the caudate nucleus, the prefrontal cortex, which helps us organize and execute tasks. There are strategic lesions in locations that can cause cognitive issues. And then there's this question of lesion burden, and in what locations are the lesions, and can that contribute to cognitive issues? And I believe it is true, and I just don't think the literature has expanded in that direction as well as it should. But I fully believe from seeing a number of familial patients that there are cognitive issues that come with time and with lesion burden and strategic lesions.
We have 2 more questions in just a few minutes. And we pass on those.
Thank you. My name's Kim. I have a brainstem lesion, and I had a question about, usually they say you don't get an increase in symptoms unless you have a bleed or your CCM grows in size. But I would imagine that you probably, I guess my question is, can you have an increase in symptoms even though your MRI shows no increase in size or no recent bleeds, or they're not detecting any microbleeds, but you're getting an increase in symptoms over time?
So yes is the short answer to that. If you do serial imaging of CCM, they do fluctuate in size. The signal characteristics within them fluctuates, and that happens sometimes without any change in a patient's symptoms, but other times it does happen in association with it. You don't always see frank bleeding when somebody's symptoms worsen, and I think that raises questions about what the cause of the bleeding is. We tend to think of CCM as leaky blood vessels through which there's some kind of burst or ooze. Personally, and we're seeing increasing evidence from the laboratory scientists as well as stuff clinically, personally I believe that there's thrombosis, clot in the CCM, which then provokes the bleeding, which may be why oral contraceptive pills are associated with a higher risk of bleeding, may be why the studies we've done, Kelly, myself and others, showing that in association with aspirin or anticoagulant treatment, the risks of bleeding are lower, paradoxically. Everybody worries about non-steroidal drugs, aspirin, these other drugs, but what we observe in practice is that people who've been taking those drugs for other reasons have lower risks of bleeding. So
But
I
don't
think,
start taking them.
Yes.
yeah, it's not proven yet. It needs to be done in a trial, sure, but it's tremendous. It's tremendously reassuring. I think it's for people who need to take those drugs. So that's to say that bleeding is not everything for what may provoke CCM symptoms.
I'll mention just a rare thing that happens sometimes in brainstem cavernous malformations too that some people miss is something called hypertrophic olivary degeneration, that patients slowly deteriorate like months after they have a bleed, and they slowly deteriorate and the doctor keeps doing MRIs and say, oh, it looks fine. But if they look at some of the lower parts of the brain scan, the inferior olive degenerates and people will have worsening sometimes speech, sometimes eye movements called nystagmus, if you've ever had the bouncing eye movements, or sometimes hemiataxia on one side. And so sometimes the symptoms might be due to something else. I also have a patient that has this enormous developmental venous anomaly that we think some of her fluctuating symptoms of the brainstem cavernoma is more the DVA than the cavernous malformation. So there's other reasons people can have symptoms. So individually, it would just be hard to say in your specific situation, but there are other things too that can be downstream of the cavernous malformation.
Yes, I have a question. You mentioned.
In front of your face.
Oh, sure. I have a question. You talked about the functional MRIs, that you may do functional MRIs, and you also mentioned that you have to do the right imaging, like SWI. I think the second one is QSM, if I'm not sure, if I remember right. So my question is, under what conditions do you do those, and how often?
Very good question. So the standard imaging that everyone should have, their standard sequence is called T1, T2, T1 with gadolinium, which is a dye, which I think you only need for the first scan to make sure it's not a tumor or something else. Otherwise, once you've established the diagnosis, you don't necessarily need the gadolinium. But the important sequence is something called SWI or GRE, which is a fancy scan that looks real funny, but the cavernous malformations show up as these black dots. And that helps us tell if it's the familial form or the sporadic form, and also kind of helps us tell where the other lesions are in case, again, we're trying to figure out what's symptomatic or not. QSM is sort of still in the research phases. functional MRI is commonly used pre-surgically to decide, oh gosh, are we going to go into the speech area of the brain, or are we going to go into the motor area of the brain, and that's a bad place to go. So those are usually pre-surgical. We don't usually do those routinely. So those would be the standards. So we hope so, but it's not always done unless your doctor, I always ask for it specifically, and ideally on a 3 Tesla. So Tesla is the magnet, how strong the magnet is, so that, and 1.5 is the original generation scanners, and there's 3, which would be more standard, and then we have 7 as well. But the SWI, in some places you'd have to ask for it. Hopefully at the centers of high volume centers would know to do that routinely, but I don't think it's always true everywhere.
Do you have anything to add, or is that?
No, I
Yeah,
don't.
okay. Oh, you do?
I agree.
Oh, he agrees. All right, everyone. Please thank our experts. And I think what we need to do now is have Dr. Hassan come back and answer questions rather than you hearing from me, because you can hear from me anytime. It's almost 10 of, and I know you got to go. So.
Well, I have to go, my cab's at 12:30. So.
Oh, yes, yeah, I heard 12 o'clock. All right. So, all right, we're just adding one member to our panel of question experts. Other questions? Or did you want to answer some of the ones that I didn't ask there?
I think didn't you ask?
I didn't ask them all, but I thought I hit the top.
Well,
Okay.
can I ask a question too?
Yes.
Oh, that's awesome. All right. So the 21st Century Care Act in the United States basically is to be more transparent with patients. And so sometimes you will get your MRI results before us. And that's created a lot of messages to me asking me what is the what does the cochlear nucleus mean, or what does this mean? And so how would you like your doctors to tell you ahead of time about this, or be proactive in terms of having that follow-up, or having a follow-up appointment, so that to make sure that questions are answered? Does that create anxiety? Are you, not really?
Anybody want to answer into the microphone? Have like a sentence or two?
Helpful or anxiety provoking
Okay,
to get the results before the
Seema
doctor?
and then Ron.
I would say for me that having the facts is good, so it doesn't create anxiety. What creates anxiety is the unknown. So I appreciate knowing all of it. And then I think that if it is something alarming, that as usual as before, that we get a call from the doctor versus seeing something huge in the brainstem and then I have to ask about it. That if as a patient, I think we would like to feel that if it's something alarming, we're getting a call right away. If I'm seeing all these things, but I didn't get a call, then I probably know that it's not something I need to be immediately alarmed about.
Ron, Kim, and then Paul.
So I'm the spouse and parent, not the patient, and of a familia. And so I think the more information has generally been good. And a recent visit to the neurologist, instead of starting without me, she says, if your husband's here, bring him in. Because there's things I'll observe that my wife's not aware of and things. But what was interesting on one of them, and this is a symptom of balance, the neurologist went through a series of different reasons that the balance issues could occur. And then she looked at the MRI and said, oh, your recent bleed was in the balance section. But I have to say, when I go back, I'm glad she didn't look at the MRI first and just say, it was definitely that, because it gave a broad spectrum of things, and it was helpful to actually read some of the MRI results. Whether we got them before or not, I don't recall, but it's also, being familiar, it's been interesting to share things with her siblings, people within the family that all have different symptoms, but have the same, share that same gene.
I do want to tell you our personal experience. So the last MRI report I got said, and yet again, we visualized the meningioma, and it was like, but wait, this is the first time I've ever heard of this meningioma. It's the first report that it's on. So that's when, for our family, is a little bit anxiety provoking when there is a yet again, and how come we didn't know that before? And that's when I would like write you and say, hey, you know, and they did. They went back and looked at the 3 previous scans, and it was there before. It was just never picked up.
I'm just going back to your question about do you want to know ahead of time or not. I just had my brain MRI about, I don't know, a month ago, and I think I'm now seeing my neurologist next week. So if I had to wait 6 weeks to know the results of my MRI, that would be very anxiety inducing for me. So it is good to know. And Google is wonderful, but you have to take that all with a grain of salt, because I probably had 1,000 microbleeds according to my brain scan. So you're just really being diligent about that. Yeah.
That's all helpful and good to hear from everyone about that.
Did you have something more to add, or did you want to? Okay.
So the way I look at it is that I can interpret what they're saying, but I tend to go to the Google machine, and it creates massive anxiety. All right. So really getting the scans myself and not really understanding exactly what's happening can provoke an enormous amount of anxiety. And I would rather it be something, a very quick follow-up with a doctor to have a real discussion, because I think it is dangerous to get too much information, especially, well, we went through an enormous amount, and it was very complicated, and there wasn't a lot of information. And the information we found was difficult. So, and even actually talking to the doctors, they didn't really seem to know a whole heck of a lot at that point. But I'll leave it at that.
And I think you're bringing up a good point, and several people have brought up the point. I think it's real important to look for the centers that are designated by the Alliance, because hopefully you'll hear the bleeding risk and the risks of treatment and things from people that see a lot of patients with cavernous malformation. So I applaud Connie for developing that program and looking for those places that are able to help people better.
One tiny comment. I think the most important thing is to see your scan rather than read the text. That's the most informative thing when I'm sitting down with patients. And in the
For a physician to see the scan, not for the patient.
Yeah, for the patients with
Oh,
with
okay.
the doctor.
With the doctor,
Yeah,
though, not
absolutely.
not in the privacy
yeah.
of my home, really.
Yeah, no. But we're talking about seeing the text of these reports. But I think the major issue is to sit down, have a real understanding of what's going on with the doctor, with the scan. I think the text can sabotage that process because you're on the back foot. Reading, you've got there's mild small vessel disease, and there's maybe this, maybe that. You know, nobody's brain is normal on an when MRI scanned, so you can be wrong-footed by that, which then puts you one step back when you come to sit down with the doctor and say, right, let's look at the scan and what are we going to do. So I do think there can be too much information.
I personally do it differently because, again, for that anxiety provoking things, and patient, when they see something, they dwell on it, and it just pesters. And so the way here we do it, if you live 4 or 5 hours, we try to bring you the night before, the day before. We have you get the MRI, and because sometimes it's unusual because the capacity and so by the time you see me the next day, the report and the MRI available. So together we go through the sequence one by one, and we address everything that's mentioned. And so you don't have to. The power of an anxiety that I've seen with patients, it's amazing. And we personally, not because of CCM, but my wife is a cancer survivor, and we look at, she's a doctor, she's a trauma surgeon. I mean, it's like, and she look at the PET scan, and she reads it quickly, and then she just like lose it because she doesn't understand is that recurrence or not. So living through it, we understand that. For the people who live close by, we bring them the same day. We get the MRI and come and see me. And I do tell them, like, hey, by the way, this is what I think, but call tomorrow or after tomorrow, the official report will be available. Do not get alarmed or anything, just call. And that's how things that help really, instead of ordering the MRI and see your patient 4 or 5 weeks. I argue against it, and I hope other my colleagues, this is how we do it. I'm here personally because I know the power of anxiety and just pestering and looking, Google, and then suddenly, like I told you before, you get this differential diagnosis and it says, oh, I have a cancer now? You know, because it's mentioned that it could be cancer, it could be things, and it's like suddenly your mind is just going everywhere. So I think these things, at least we do to help with anxiety because it's powerful.
Thank you. Do you all have other questions for our audience, or should they be asking you questions? Do you have one more, Kat?
Yeah, well, so I was recently on Amazon, and I noticed that there are several books written by patients. I only found 2 on Cavernous. Is there more? I would love to see some emotional provider or care provider of a patient write a book too.
Anybody up for that? So, yeah, so any budding authors in here who are caregivers? Don't look at me.
I'm not looking.
Okay.
I'm looking at Rustam, trying to get him to ask a question.
Okay. Do you have a question for the audience, or should the audience ask you questions? Okay. Other questions? I deferred Candace last time because she can ask me questions anytime. So.
I want to come back to something you said about surgery for epilepsy to remove the hemosiderin stains. Are there any alternatives that are being explored now to the surgery? For example, a drug that could maybe remove the hemosiderin stain for some people who might have hemosiderin stains in the eloquent tissue that can't be removed.
Do you want to answer whether laser?
Yeah, so I'm a surgeon, so I'm going to speak from a surgery perspective. And again, it depends where the tissue is or not. So if it's non-eloquent tissue of the brain, we recommend surgery because that's curative, almost to 70-80% cure, or with certain medication, so you can down from 2 medication to 1, anything. So we be very aggressive about taking the hemosiderin, and we'll go after it. But in areas of brainstem and eloquent tissue, you cannot afford that. You have to stay within that sidrin because that's your guideline not to wander around, because once you get out that, patient will have 1 millimeter of that tissue is complete devastation. So it depends on the areas. Now, medications, we learned, like for ICH, intraparenchymal hemorrhage, there are multiple trials that are done, which is same thing as bleed, and the bleed with time, the red blood cells lyse, and they leave iron, which is a yellow stain. So the hemosiderin is iron. It's a yellow stain on the tissue. Once brain tissue stained like that, there's no way you can remove it, except surgery. However, during the process, while the red blood cell lysis, can you remove it? There have been trials of, use defroxamine. I use now, working with subarachnoid hemorrhage, I use deferobrone. But so far, it's still all experimental. Nothing specifically medication out there that tells you can remove that. And again, you cannot move it when sustained. It's the process. If this medication is going to work, it's during that process. Capture, bind to that iron as it's in, then remove it. Beside the open surgery, which is the knife and suction and everything, people talking about the focused radiation, the laser therapy, and just kind of like we do it now for epilepsy surgery. Before epilepsy surgery, everything is you go through the brain, cut that tissue block, and move it. Now we go in with the laser and just kind of disconnecting the wires, if you will, And once you disconnect that, hopefully you reduce. From epilepsy surgery for temporal lobe and amygdala and hippocampus, it seemed to work as good as the surgery. So have anyone done it for seizure, CCM provoked seizures? I don't know, I'm not aware of yet. But again, we're gonna explore, that's a platform. Hoping that it goes forward because it allow to include these patients, because again, there are small series, a little here and here, a little there, but it allows for comparison. We have control and everything. And with patient, and that's why I say the Center of Excellence are really what I hope. And I'm one of the people who, example, I focus on aneurysms about 11 years ago. And the only treatment you have for aneurysms, either surgery or watch. But we came up with, I was the first one, and that's how my fame came, is I suggested aspirin. And since then, we proved it in animals, multiple studies, longitudinal, worldwide, and it works and helps stabilize it. So it didn't happen without innovation, without pushing the envelope, but that wouldn't happen without partnership with patients. You have to be upfront, research protocols to push the envelope. Like if we use the focused ultrasound, it has to be through an IRB, and we have to find a certain patient. For the LIT, the same thing. For the laser, same thing. So unless there's a partnership, and the NIH is not going to fund these trials. I hate to say it. So this is where the dilemma. You want to be in an innovative place.
Okay. We have about 5 minutes before they're going to go off and have lunch. Was there another? Okay, I'm giving the mic.
I was just curious if the brain kind of heals the same or like with subsequent bleeds. So most of my symptoms resolved fairly quickly after my bleed, and mine does not come to it's in the center of my brainstem, so it's not to the surface. So if I had another bleed, would it kind of heal the same way, or could I expect further deficits, or just?
So we've been interested in that same very question. How many bleeds does it take before somebody's disabled by it, and is there a way to quantify that? And it's very hard to look at that, but we've been looking at patients on an annual basis. How are you doing? Have you had surgery? Have you not had surgery? Have you had a bleed, not bleed? And looking at that, and we found that most patients after a first bleed get back to what we would call a normal or near normal level, and that's not everybody. And after a second bleed, it's almost 80–90% of people will get back to near normal, or at least a functional where they can go back to work. It's really, we see the kind of the trail go down after a third and fourth bleed, that then the people aren't bouncing back and requiring more help. But again, that's not your individual case or anybody's individual case. It's just in general looking at our pool of 400 patients.
And does from my understanding, that the brain heals more from a bleed than it would from surgery?
Yeah, I mean, that's a hard question. We think that probably the blood kind of pushes the nerves away initially, as opposed to rips through them, because some of these bleeds, if it was a hypertensive bleed, for instance, patients just don't bounce back from other types of bleeds or aneurysmal bleeds, whereas patients with cavernous malformations tend to, the first time at least, get better. Surgery, oftentimes there's a temporary increase in symptoms immediately post-operatively in everybody, but then the long-term 1-year outcome depends on everyone's individual situation. And I think to answer more about the surgery, that Rustam is looking at doing a clinical trial to look at those outcomes that you're looking for.
I suppose the other thing to remember is that a bleed from a CCM is on average less than a teaspoon in volume. That can be a lot in the brainstem, for example, but elsewhere it may not even be noticed. in other parts of the brain, whereas an older person with a history of high blood pressure, small vessel disease in their brain who has a brain hemorrhage, it's several tablespoons on average. So one of the reasons why CCM bleeds, the vast majority of survivors are independent and are not significantly impaired, although they may have symptoms, is because of the relatively small volume of bleeding. But this business of things getting worse over time from rebleeds sometimes is really due to what the volume of the blood is and where exactly it's bled. And predicting that is really hard because, you know, as we've said earlier, CCM vary in their size a bit over time, and where these little beasts may grow into or may bleed into, you just can't predict that. But all we can go is on the population average, which is generally reassuring for people like you.
Okay, we'll take one last question from Seema. Wait for the wait for the microphone, and then we'll break for lunch.
Just to follow up on that question, so do you think then more bleeds causes more symptoms because remaining hemosiderin in the brain and there's more of that? Or is it more of the stress on the brain? What do you think?
So just an example, I do agree with my colleagues about with cavernoma, it tends to expand. And I use the analogy for a patient is like a rubber band. You can stretch, 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 stretch. It comes to a point, if you stretch it 1 millimeter, it will cause symptoms and will continue to cause symptoms. Example, when I showed you that patients, the two patients up front, that they had, the vision problem. Well, it's confined space. It's very confined space. It's a cone. And it will bleed and they will recover. But as it becomes bigger, it's going to completely compress the optic nerve and will cause vision loss. So sometimes just the mass effect from growing and bleeding, and it's because it bleeds and it organizes, the clot itself organizes, become fibrous tissue. And that mass effect with time could lead permanent damage. Not only that, too, even though with bleeding, like in the brainstem, the first time you're lucky, you're bound. The second time, it starts affecting the hemosiderin because the hemosiderin itself brings inflammation, macrophages and everything. And that this repetitive things could lead to fibrous tract injury. But again, they're not, I don't think they can cause symptoms, but they're not devastating. I think so far, I haven't had a patient that done third bleed or fourth bleed, because by the second bleed, even in the brainstem, as long as they come to the surface and we have corridors, we can go after them, but we warn patients about the consequences. And as long as we avoid the DVA, like I told you before, and we'll stay within the hemosiderin, the staining, I think the patient tend to bounce back just fine.
I'm determined to end on a super positive note, because we've been talking about accumulation of disability and so on. I think some of the cohorts of patients we've been following, and Kelly's got a huge cohort in the Mayo Clinic and in Scotland. We've got many hundreds of people who've been following up, and in my own practice, people with CCM may occasionally have bleeds again in the future, but it is occasional. The risks, there are some very high-risk individuals for whom it's a problem early on, but in general, for the vast majority of people, things go quiet. I wait for contact from patients again to say I've had another bleed, come back and see me, but it happens very rarely. So overall, there's the initial high-risk period after the bleed, when all these decisions are front-loaded, but for the vast majority of people who get through that phase and are living with CCM and haven't had surgery, for example, it's not a life of endless recurrence of bleeds. Seizures is another thing. But you can be reassured that when things have gone quiet, the risks remain low. And whether they get lower and lower and lower over time is also uncertain. How often do we see patients who had a bleed 20 years ago coming back with another one? I hardly ever see that. So I think it's important to...
Yeah.
What,
yeah. I showed you a patient that 10 years later, and I think part of it is you know.
But we can show examples like that.
Examples,
How often
but
does
not-
that happen in your clinics? Hard is very rare. In the totality of all patients, you see?
No, I want to add on a positive note because the other thing that's found in some of these studies is that even though the bleed risk is maybe 50% over or 30% over 5 years, the risk of a severe bleed, disabling bleed, is actually much lower, around 8%. So just because bleed doesn't always lead to disability, but and that's why I continue to follow these patients, because occasionally we'll see people that have these, maybe they have 2 bleeds in their lifetime, but they're 10 years apart, or the patients with familial form that go for years and years, and I see them back with something new. So I think we need to extend out our natural history studies to see these patients that how often is it that they come back every 10 years? Because you see the ones that come back because the ones doing well don't come back. So we need to keep following these patients in a study.
But that's what
Just kind of similar to thing. He wears the glasses, rosy and everything. We looked at the same thing as AVMs. AVMs, they did the Aruba trial that came in, and they looked at which is much more worse disease, and they looked at Aruba, and they looked at the natural history 3 years, 4 years. And it's just like a surgery versus, actually surgery is worse than just leave it alone. But you look at the Finnish group, which as I did 6 months over there, fellowship, they have registry that goes back to 1920s. So they were able to follow these patients 30 years, 40 years, 50 years. And guess what? It really is bad to leave it alone. Yeah, AVMs. AVMs, but I'm just saying, I'm just an example. CCM, I agree. That's why I said earlier, AVM is worse. CCM, we don't have 10 years follow-up. We don't have 15 years follow-up. We do? 15?
Yeah, we've been going for more than 20 years, since
For how many
1998.
How many patients?
About 300.
Oh.
But that's what I mean, putting these things in context. So you hear us disagreeing here because, yeah, sure, I've seen people with a delayed bleed 10 years down the line, 15 years down the line, but it's very rare. You'll have them in your consultation rooms. But if you look at it in the context of the hundreds of patients we have seen who haven't been treated, about on average 15 to 20% of patients with CCM in Scotland have surgical treatment. The remainder don't. That may be a bit of a different proportion in the States, I don't know. But those people aren't coming back endlessly years down the line back to my consultation room saying, I've had another bleed. If you look at the whole denominator. But we do occasionally see people like that.
We're off the hook here.
Yeah, I'm bringing out the hook.